from the VA St. Louis Healthcare System, and also a member of the steering committee who put together the forum today.
I'd like to give a hand to the steering committee. This is the first probably meeting, and this has been about the smoothest I have seen an organization do a presentation in a conference like this that I've ever seen. So yes, everybody that's on the street. Can you hear me now? No, so I lead what's called the ACOS Mental Health Services at the St. Louis VA. That's just a fancy acronym for basically saying I try to run mental health services. Right? I'll tell a story to start with. I was a psychologist by training. I did my undergraduate at the University of Kansas. I did my internship at the Phoenix VA and Indian Health Services, and my postdoctoral work at the Seattle VA. And I came to St. Louis about 16 years ago for a frontline clinician's job. My specialty is pain management and addiction. And about 10 years ago, I started getting into administration because I was a sucker. I won't say no to things. And one of the things I've noticed about administration is that despite what your training is, you're never quite prepared for what administrative tasks are sort of facing you. The current kind of dilemma that I am having right now is that we're going through our annual inventory review. And so one of the things that we do every year is we basically check to make sure that we have all of the equipment and everything's sort of accounted for. And it turns out that we're missing a piano. Now that sounds strange, but it gets even weirder than that because this piano was actually bolted to the floor in our locked psychiatric inpatient unit. And no one knows where this piano is at. So now my administrative officer and I are all sort of roaming around trying to kind of find this piano. And I'm asking all of you that if you see a suspicious piano anywhere, I want to know about it because it might be ours. Let me talk. I'm here really to talk about VA and VA mental health services just in general. Okay. So let's talk about the facility just as a whole. The facility as a whole is St. Louis is a 1A facility. In the VA parlance, they basically rank facilities in terms of how complex and how big they are. So how much services do you provide, and what are the complexity of the services that you provide? And 1A is the highest rating that you can get in terms of complexity and the amount of services that you provide. So essentially what that means is that the St. Louis VA provides almost any type of medical and mental health and rehabilitation services that you can kind of imagine. Residential, community-based, med-surg, primary care, mental health services, basically anything you can almost imagine. The only thing that the St. Louis VA does not do that I know other VAs do is we don't currently perform solid organ transplants. It's the only thing that we are not involved with when it comes to kind of offering medical care. And when you think about mental health within the St. Louis VA, we have a similar type of scope. As you listen to me sort of describe the types of services that we provide, what you'll essentially start to see is that we have community-based services, we have residential programs, we have inpatient programs, we have specialty outpatient programs, we have integrated mental health services. Basically almost anything that you can imagine a mental health service doing, our mental health has something going on there. We have 4 community-based CBOCs. Those are basically outpatient clinics with some mental health integration into it, and I'll talk a little bit more about that in detail in just a few minutes. But those CBOCs are located in St. Charles, Washington. We have one in North County, and we also have another one in Belleville, Illinois. We also have the Hope Recovery Center. The Hope Recovery Center is essentially just down the street here, a couple of blocks, and it's our homeless programming services. And so we have a very, very healthy homeless program, and that is a one-stop shop in the Hope Recovery Recovery Center. So it both offers social support services to help veterans obtain secure permanent housing, but it also has integrated mental health services and integrated primary care services. So for a homeless veteran, they can go to the Hope Recovery Center, they can talk to a social worker about getting plugged into a voucher system that helps them support rent. They can also walk into a primary care, receive basic primary care, and also mental health services there. And one of the themes that you'll hear me talk about as I talk about the services that the VA offers, or the mental health offers in St. Louis, is you're going to see that I really talk a lot about integration. And we're going to talk about integration and the importance of integration as we go through these slides. So what does the homeless program do? I've already talked a little bit about it. We have what's called an HPAC team. That's a homeless-based, that's a homeless primary care team that is integrated with mental health. So it's a primary care provider, nurse, psychiatrist, and social work. The other thing that the home-based primary care team has that I think the VA does a really good job with, and our VA has really embraced this, we also have what are called peer support specialists involved in the home-based primary care, or the HPAC team. So what are peer support specialists? Peer support specialists are veterans who have had their own journey and struggle and have worked on their own recovery from mental health with mental health difficulties or substance use issues, who we hire on, and they become part of the treatment team. So peer support is really that. It's a peer, it's a veteran who also has had issues with mental health and substance use issues, that has worked their recovery program, and is now lending a hand to veterans in the area. We have veteran treatment courts. That has really taken off in this area. So when we first started about maybe 10 years ago with veteran treatment courts, there was one in the area. There's now 7 to 8 different types of treatment courts. If you don't know what a treatment court is, if you, for veterans who run afoul of the law, for minor to moderate types of offenses, what they will sometimes do is the courts will divert them into the Veterans Treatment Court. That treatment court sort of oversees, does assessments, or encourages people to get involved in treatment. And if they successfully go through a treatment program, let's say it might be substance abuse, or it might be a course of outpatient treatment, that they, at the end of a successful completion of a treatment episode for those veterans, they oftentimes can have their charges either dropped or reduced. Supported housing and emergency housing is a big push. You've heard the VA talk about, hopefully, our push to end homelessness. We have vouchers that we work with veterans on in terms of trying to get them stable permanent housing. And we also have emergency housing that we provide for people in case the supported housing is not available. Substance use disorders. We have a number of different types of substance use programs that are available. We have a 35-bed residential program. The 35-bed residential program usually programming lasts about 3 weeks. They've done some stuff that was really, I think, very innovative. So it's a 3-week-long program, but the first 2 weeks is residential, and that third week is actually outpatient. They transition the people over to outpatient. It's a very, I think it's a very novel idea, because what happens in mental health services, as some of you may know, is you lose people in transition, right? So when you transition from one program to the next, or you transfer different providers, or you finish one residential program and now you're moving to outpatient or some type of outpatient services, you really have a high degree of losing people in those transitions. And what that third outpatient week does is it basically gives people an ability to sort of ease that transition out of the residential program. I think I thought it was a very novel idea that Ann Lovell, who is here today, helped put together. Very good, yeah, right. The residential program also has an intake of outpatient program, and then we also have an opioid use disorders clinic. The opioid use disorders clinic both does Suboxone and methadone. We also have a domiciliary program for homeless veterans. This program is designed both to help people maintain or achieve stable housing, and then it also is designed as a return to work program. So the overall goal of the DOM program is both stable employment and stable independent employment and stable housing. This is a 35-bed unit. Its average length of stay is around 6 months, so it's roughly 6 months. It's integrated. There are both vocational rehabilitation services, mental health services, including psychology and psychiatry services, and then just a whole bunch of other sort of life skills and building formats and resources that are available. I want to brag on the DOM for just a second. So the VA takes a look at, so when somebody successfully completes the DOM program, what's the percentage of people who leave the DOM with competitive employment, secured competitive employment? As of last fiscal year, our DOM was second in the nation, with an average of over 70% of the people who finished our DOM actually left the DOM with secure, independent employment. We have mental health and intensive case management services. For those of you who work in the community, if you've ever heard of something called assertive community treatment, mental health intensive case management services is the VA version of that. It's basically our community-based services for people who have severe mental health illnesses and who are having trouble engaging in more traditional outpatient therapy. So, in order to become quote-unquote eligible for MICM services, we're talking about the MICM program targets veterans who have had, in a calendar year, more than 3 hospitalizations, psychiatric hospitalizations, or more than 30 overall days of inpatient psychiatric care in any one 12-month period. So we're really kind of talking about the MICM program as being a program that really targets folks who are struggling with mental health issues, severe mental health issues, and who are not sort of reaping the benefits of our traditional outpatient services. And so when we talk about community-based services, that's what exactly it is. We have psychologists and social workers getting in cars, driving to the veterans' home, providing mental health services to them, helping those veterans transport to and from the VA for other mental health services and other medical services. It's an incredibly great case management study. And just like with assertive community treatment, what you'll see with folks who get engaged with our MICM services is that their rate of inpatient psychiatric utilization, which is a rough indication of how oftentimes these people are in crisis, really drops through the floor. Over 50% reductions in hospitalizations, over 50% reductions in the number of inpatient days that a person may spend. The Psychosocial Rehabilitation Recovery Center, I hate when I say this, but if you think about a day treatment program, they're sort of like a day treatment program. They always say, we're more than a day treatment program, and they are. They have a lot of integrated mental health services that they provide also. They offer group programming and individual coaching to people who have severe mental health illnesses. Very recovery-based, very recovery-focused, and they do a lot of really cool stuff. They also do a lot of stuff in the community where they have groups where they teach veterans about volunteerism. They'll go out into the community and do certain types of volunteer work, all with PRC coaches. It's a very innovative and cool program. Once again, individualized services, group therapies, and community-based services. Inpatient and outpatient services. So our inpatient program is that we have 40 inpatient psychiatric beds. Those beds are basically used for all of St. Louis VA, for the Marion VA, and for Poplar Bluff. The Marion and Poplar Bluff VAs have outpatient mental health services. but they do not have inpatient services. So we basically serve as the catchment area for the entire eastern part of our area. So 40 beds are available. We usually run a census of about 32 to 35. Our average length of stay is about 7 days. We have two specialty units. One is a general outpatient adult unit, and then we have also a senior veterans, a geropsychiatric unit. We try to keep the two populations separate, largely because of safety concerns and environmental care concerns. Because oftentimes the number of senior veterans that we see have comorbid problems with dementia and wandering, which makes them a little bit more difficult to both place and to care for safely. Outpatient mental health services. Now here's where we see some of the scope and complexity that St. Louis provides. It's hard to sort of identify an outpatient mental health service that we don't offer, right? So we offer specialty services in PTSD, we offer specialty services in MST, we offer general mental health services, we have an outpatient senior veterans clinic for veterans who are older and may be starting to have some difficulties with cognitive issues. So we offer sort of a vast array of services. The only mental health services that we will typically, or we typically do not offer, are eating disorders and treatment for really severe OCD. For both of those, we will fee-base those individuals out into the community because we don't have the specialized resources to deal with it. But virtually anything else that you can kind of imagine is what we do on the outpatient unit. As Dr. Shaw discussed in her presentation at 9 o'clock, very strong evidence-based treatment wing, right? So we, when evidence-based treatment kind of came up in the VA, St. Louis really decided that we were going to pursue that. So we have over 20 different providers who are certified in evidence-based treatments. And in fact, four of our providers are actual national consultants. So four of the outpatient providers that we have in St. Louis are actually trainers at a national level for the evidence-based treatments that the VA rolls out. Very proud of the quality of mental health services that the VA, St. Louis VA offers. I would say this again as an aside. In terms of how large we are, mental health services have approximately 220 employees. There's 50 psychologists, roughly 50 psychologists, about 35 psychiatrists on staff. We serve an average of anywhere from 12 to 14,000 veterans a year and have usually anywhere between 120 and 130 visits a year, right? So pretty large, okay? I'll say this too, I'm really proud of what the St. Louis VA has done in the way of mental health care, because approximately 10 years ago or so, the VA started opening up funding for facilities to expand mental health services. And the leadership at the time in St. Louis, at the St. Louis VA, really were early adopters of expanding sort of mental health services. So like I said, I've been here for about 16 years. When I was hired 16 years ago, I was one of 11 psychologists, and we have 50 now, okay? When I was hired 16 years ago, we had 10 psychiatrists, and we have 35 now, okay? So the St. Louis VA has really taken apart the whole idea of expanding mental health services. So the PTSD consultation, Dr. Gupta did a really nice job of stealing some of my thunder about the VA.gov website. If you have not taken a look at this, and you're a community provider or you're someone you're someone who's suffering from PTSD, I would strongly sort of recommend that you take a look at this website. It is frankly just unbelievable. On the professional side, so they sort of break it down into two categories. On the professional side, they offer free continuing education courses. They offer free consultation with PTSD specialists, right? So you can call and actually set up an appointment to talk about a case with somebody who specializes in the treatment of PTSD services at absolutely no cost. And that's not just for the employees, that's for the entire community. On the patient side of things, there's just a tremendous amount of educational materials about how VA impacts families, about what types of treatment options there are. There's also a really cool video clip where you can kind of go and see different veterans talk about their experiences with PTSD and their experiences with the different types of treatment. And they have it organized such where if you, as a 48-year-old white male, if I served in the Marines and I was interested in PTSD services, their refinement is that I can actually find a video clip of another 48-year-old white guy who was in the Marines talking about his experiences with PTSD services. And so it's really kind of some really top-notch stuff, really amazing, and all of it is completely free. I have the website up there, the phone number, and email. Same-day access is another thing. If you've been following what's going on in the VA, there's been sort of this idea of different ways that you can get same-day access in the St. Louis VA. So one is through our emergency department. Okay, we really try not to use our emergency department as our same-day access vehicle. Okay, and why? And why would that be? Because emergency rooms are terrible places to go, right? I mean, they just are. The wait times are long. You oftentimes are not going to get as thorough of an assessment as you probably should. So it is just, so we basically say that if we direct people to the emergency room, we see the emergency room as this is the place where we have already decided, based on some assessments, that you need to come so you can be admitted into our hospital. So we traditionally try to avoid at all costs using the emergency room as the place where you go if you need a medication refill, or the place where you go if you just get plugged in, just to get plugged into mental health services. We try to avoid that like the plague, because that's something the emergency room is designed to try to manage emergencies. Okay. And so what do we do with that? So how do we help with same-day access? Well, one of the other things that St. Louis was a sort of an early adopter of is this whole idea of integrated mental health services. And so what we have at the St. Louis VA is we have a psychologist embedded into every primary care team in the St. Louis VA. And what do I mean by that? I mean that there's a physical psychologist, a full-time physical psychologist that has an office in the primary care suites, and their clinic is set up such to where every other half hour is open for walk-ins. Okay? So that basically means if you're a primary care provider and you're sitting down with somebody and you feel like, gee, I think this person might benefit from some mental health services, in order to access mental health services and get them seen by a psychologist in an initial evaluation, you probably have to wait at most 30 minutes. Okay? And it's a walk over, and it's a walk across the hall. Okay. Now, why is that important? And why do you think that trying to have that decreased barrier is important? Anybody?
There's a stigma of mental health.
Yeah. So if somebody wants services, now is better than later, and that's absolutely true. And then I heard somebody say something about stigma, and stigma's right too, right? So if you're sort of uncertain about whether you need services or not, you're going, I don't know if I need services or not, and my doc is saying maybe I should go see somebody, how likely am I going to see somebody if my doc walks me across the hall versus here's a consult, they'll contact you, you're going to have to go to a different facility, a different building. It'll be, even if the access is a couple of weeks, right? It creates some barriers that make engagement more difficult. And I want to really kind of drive that point home, because when we talk about sort of engagement, and we talk about trying to drive down barriers to engagement, so making it easier for people to engage, making engagement quicker. And the way I think about this is, I'll ask people, I'll say, well, close your eyes, okay, and think about when you were 22, 23 years old, okay? You think about when you were 22 and 23 years old, and think about what would have to be going on in your life for you to think to yourself, maybe I should go see a mental health professional. Young Fred, 23, 24-year-old Fred, my life would have had to be a dumpster fire wrapped in a felony, okay, for me to think, gee, I might need to go see a mental health provider, okay? And that is even me thinking about maybe I need to go, not as much as even asking for help, okay? And so I really truly believe that part of this is some of the reasons why we're seeing difficulties with engagement is that people just don't think about seeking mental health care because of stigma, because of concerns that they might have about their career, because of a whole list of different reasons. So the easier that we can make it for them, the better. That's why we do screenings, that's why we regularly ask people about their mental health conditions, and that's why we have integrated services. And the integrated mental health services that we have isn't just in primary care. So we have a psychologist that's embedded into our multidisciplinary pain clinic. We have psychologists that are embedded into our spinal cord injury units. We have psychologists that are embedded into our community care. Basically, the idea is to try to have access as quick and as high as level as we possibly can. Does that make sense? Here is a bunch of people's names. These are, this is my leadership team. I'm really, really fortunate to have a bunch of very wonderful and very committed people working in mental health services. And all of these individuals are either program managers or lead certain kind of important elements of mental health services. And all of these individuals, I have the phone numbers. Main phone number is up top, and then the extension is down the line. Those extensions are direct extensions. Okay. So if you call extension 64623 and I'm in my office, I answer the phone. Okay. If you need some help, we'll give you the help that you need in order to get somebody services. And that includes, hey Fred, we have this veteran and we're trying to figure out if he's eligible for services. Hey Fred, I'm having a hard time getting my veteran into the inpatient unit. Hey Fred, I don't understand the damn thing that you said about the services that you provided. Could you please review the stuff that you do? Whatever you want us to talk about, we will be there for you in terms of trying to help this out. Because the community forums like this have the right of it. The VA cannot do all of this on our own. Okay, we need people's assistance. And as we talk more, and I'll talk a little bit more about Veterans Choice here in just a second. But as we start to kind of be more, as we start to move into Veterans Choice, there's going to be more and more need for collaboration between the VA and community partners. Eligibility. So on the table, there's a handout that covers this material. There's a website that people can go to and they can fill out forms on the website. They can call numbers, they can send in stuff by mail. We try to make eligibility as easy as possible. And one of the things, I am not an eligibility expert, so I'm not going to talk to you about who's eligible for what. But what I can say is that my general rule of thumb is that if a veteran is interested, they should apply. That bottom line. That will let you know if you're eligible or not. It's very likely you're eligible for services, right? There's very few individuals who are not eligible for services. And the other thing that I'll say too is if it's a crisis situation, if you're having a situation where you feel like this individual is at danger of hurting themselves or hurting someone else, or the person just seems to be really sort of decompensating in sort of way, bring them to the VA. Okay? Bring them to the VA. We will offer at least emergency services to this individual. And then if they're not eligible for services, we'll sort out what we need to do in order to transfer a person into the community. Okay? So bring people by if you need to bring people by. So let's talk about choice. If you've been unconscious, you've heard stuff about choice. So in the current format, what choice basically says is that it gives veterans the option to go into the community if they live 40 miles away from a facility, or if we can't provide care within a 30-day framework, right? And so how does St. Louis use it? Basically just like that. What I can say is that there's very, very little services. There are very, very few services that we that we have over a 30-day wait for. In fact, I can't remember the last time we fee-based somebody out choice because we couldn't hit that 30-day mark. Now, what I will say is that there's some areas that we will choice out because we just don't have the internal capacity, the specialty, like for eating disorders, for severe OCD, we'll use choice because we essentially don't have any providers who do work at the level that needs to happen. Okay, we do oftentimes see people go out for choice with a 40-mile radius. Now, Choice 2.0, which is currently still in legislation, right, is proposing that they get rid of the wait time and the distance restriction. So essentially what Choice is saying is that what they want veterans to have what amounts to essentially a voucher option, okay? Where if you want to go to the VA, you can go to the VA. If you don't want to go to the VA, you can go to a community provider, and the services will be paid for. Okay.
Brad, the current funding for that is being extended at the time of being extended for Choice, correct?
Yeah. So Choice 1.0, its funding actually expired a little while ago, but there was the president extended that, right? And so the idea was that they extended that funding for Choice 1.0 in sort of preparation for in preparation for the second, right? Okay. I'm not going to go through a ton of this. You can become eligible. So there's information on this slide and in this slide deck that talks about how providers and institutions can become choice-approved providers, right? You have to be willing to accept Medicare rates. That's what the VA pays community providers to provide services, and the process is basically completing some paperwork and getting sort of recognized through a third-party payer system that they adopted for the choice program. That's the resources there if you want to become a choice provider. And that is it for me. So are there questions? Anybody have any questions about services? Yes, ma'am.
What's the eligibility for to go into there? What's the requirements to be considered for the domicile?
So homeless, okay, and yeah, it's HUD definition of homeless, right? Which is somewhat bewildering to people, right? Because the HUD definition of homeless is consider some people housed. That when I look at it, I would say I'm not sure I would consider that person housed, but it's the HUD definition of homeless. The program about 2 years ago started to change its focus some. It used to be really if an individual had to be willing to work towards competitive independent employment in order to be eligible for the DOM. About 2 years ago, they started changing that criteria now, and now it's now they will accept people who are currently trying to get their disability situation taken care of, right? So in other words, they will, yeah. So it's really more. So really, it's more that they get discharged with a stable income stream, whether that's through Social Security, VA benefits, or a competitive job. So there's been some opening of the admission criteria for the DOM.
So what's the typical person that would be put into the DOM?
Well, I would say it's hard to say typical. I would say that most individuals are have some degree of a comorbid substance use issue. right? And I would still say, even though we've made that change to allow people to come in, most people are still looking for some level of competitive employment, right? And I would say also, and Ann probably would agree with me, what we are seeing is a younger cohort now. So you're seeing guys in their mid to late 20s. And the other thing with substance use, the other thing that we're noticing is heroin or opioids is a really big deal. And so that is actually, that's become quite a big concern of ours.
So I know the Dom has beds for women, all the programs that you talked about, accessible for women as well as men.
Yeah, that's correct. So for all of our outpatient programs, obviously there's accessible to female women. But yeah, but for inpatient and all of our residential programs, we have designated beds for women. And essentially what that means is that there's some increased security on the units for women. So they have rooms that lock from the inside, and the rooms are usually situated in areas that we can monitor more closely. Yes.
Your peer support person that you talked about earlier, you said that they normally are someone who has had an alcohol problem or a mental illness that they have overcome.
That's correct.
Is that if and or both and? Is it, could they have one of
They
those
can have
two,
one.
or do they need both?
No, they don't need both. All right, they can have one. Other questions?
So we were seeing that the psychologist embedded in all the offices that the primary care is at both Jefferson Barracks and John Connor.
Yeah, it's the psychologists are embedded in both the John Cochran, Jefferson Barracks, and then in all of our CBOCs as well. So all of our outpatient community-based services, right? And they're all sort of set up the same way. What they'll do is that they will take people who need maybe shorter-term treatment and will follow them for a short course of treatment, but they're really designed to keep about 50% of their time open for open access for walking. Yeah, so there's possibilities to walk in for primary care. I believe at this point all primary care teams at the St. Louis VA have sort of the expectation that somebody walks in and says, I want to see my primary care provider because they have something going on, that they're provided with some level of same-day access then, right? We also have a triage. They have a triage service that will also provide same-day access. Yes, sir.
Since we're at SLU, could you talk about your interactions with the medical and professional schools?
Oh yeah, yeah, I think that's a great question. We have a psychiatric residency program, or we use SLU psychiatric residents, right? And so we have 2 psychiatric residents who are in our outpatient areas, and then I think we have anywhere from 3 to 4 that rotate through our inpatient units. They also, the psychiatric residents also have a smattering of other rotations and other specialty services. So, like extended care, will have a psychiatric resident come through just for that experience. SLU psychology is a little bit different. Psychology training is different than psychiatry training, right? So we'll occasionally have our interns and our postdocs are year-long paid positions for both, so it's both a year internship and a year postdoctoral program. It's a competitive program, so you don't typically see VAs with their affiliates having some type of arrangement where their graduate students go into that, right? Does that make sense?
It does.
Yeah.
Geriatrics?
So I would say over 50% of the psychiatry staff that we have actually have come from our relationship with SLU Psychiatry and the residency program. And we'll occasionally steal a psychiatrist from them too, right, which they don't appreciate, but I'm okay with that. I think very good. working relationships. I would say as the ACOs of mental health service, the one area that I would like to see more involvement is I'd like to see us get more involved with some research activities. And that's probably one of my 5-year plan, one element of my 5-year plan is to try to get a little bit more closer affiliation with SLU to help with that.
Brett,
Yes, sir.
you mentioned up front about the PTSD resources online and the VA website for veterans and for clinicians. But an easy way to find that would be to type in National Center for PTSD.
Yep.
Thanks.
Okay, you're right there.
So, you said that there's more mental health professionals now than veterans do. When I assume that the more veterans use mental health services, there's better outcomes.
Oh, yes, I would say so, right? So I didn't include this slide, I wish I would have a little bit. But what you see over so once we started hiring additional staff, you'll see like the number of veterans served and the amount of services that we provide and just really skyrocket over the last, it's been over the last 10 years probably. I would say the last 2 or 3 years in terms of our growth rate of the numbers of veterans served have been relatively stable, but that's because we're staffed up, right? So I run mental health services. If somebody came to me and said, "Fred, do you want more staff?" I'd be, "Oh yeah, I want more staff," right? But right now, when you look at our access numbers, when you look at like our results for our DOM and for our homeless programs, we have very good access, and I think we have very good results. Anything else? I probably didn't answer this 47 times. So, okay.
Thank you, Fred. Here's your certificate of appreciation from Army Medical and the highly anticipated, and I just signed up here, Casa Coin. Thank you very much. A couple of people have come in. I'd like to point out that we failed to introduce earlier Curtis Carey from Midwest VA Midwest. He'll be up on the panel shortly. I believe I saw Mark Etterback from MHA come into the room here, so thank you for your support, Mark. One of the people I also would like to thank is Keith Repko. He's had another engagement of meetings with VA officials, but he's been quite supportive of our efforts here, and he and the VA team have really stepped out to really give us good guidance and support as we go forward with these types of forums. I'd like now to introduce Dr. April Foreman from Southeast Louisiana VA Healthcare System, and I'm very proud to have her here, and we went out of our way to get a fleur-de-lis carpet for you. And she's wearing a fleur-de-lis on her chain, so she really came dressed appropriately. It was hard. We got the right for you, just for you.
I'm so excited to be here. They totally did fly me in from Louisiana. I'm currently detailed to the VA's National Office of Suicide Prevention, and I'm here to give you a briefing about suicide prevention and in sort of the big VA, sort of a pullback view. But where are my suicide prevention coordinators in the audience? Where are those? Can you come up? You come up here. Just for like a minute. Because this is really great. So I am a suicide prevention coordinator from Louisiana. So I'm going to start out by telling you a little bit about suicide. And it was so funny. The general was like, she's the suicide lady, which is totally true. So I want to tell you some things about veterans, and I want to tell you about the general public. So we hear in the media all the time that 20 veterans a day die by suicide, which is a pretty good estimate. See, 20. What you may or may not know, if you looked at that same media a little bit further down in the article, is that about 6 of those veterans who die by suicide are in our VA system and clinics. okay? Where our suicide prevention coordinators are, or some of the folks here. If you work in a VA clinic, can you raise your hand? So it's about 6 of those folks we need to be thinking about are in VA care. But what that means is that a whopping 14 veterans who die by suicide every day die by suicide in the healthcare systems that civilians use, where everyone else is. And I want to talk a little bit today about that, because I'm pretty passionate about this topic, not just for veterans, but you'll get to hear a few stories of that. Because suicide is, depending on the research, the 9th or 10th leading cause of death for all Americans. More people are going to die by suicide than in traffic accidents or from HIV. It's like a 747 going down full of passengers every single day. This is a major public health crisis, and of course, veterans are 2 or 3 times more likely to die by suicide than folks in the general public. So it's a public health issue that is very much one that impacts veterans, but trust me, it's impacting everyone else. As a matter of fact, it's not just folks in the United States. We add everybody up all over the world. We lose about 800,000 people in the world to suicide every year. It's a really big public health issue. It is the only leading cause of death for which the rates are not going down. I would love to tell you that there are fancy experts who researched this, and we know why, and we know exactly what to do. But if I told you that, I'd be lying. And I happen to work, I'm on the board of the American Association of Suicidology, and if you are a fancy suicidologist in the United States or in the world, I probably know you, and I'm going to tell you what, it's really true. We're not exactly sure why. It's a really big deal. And we're here to talk today about PTSD and about suicide, but let me tell you that you've been reading in the news that if we just cared a little bit more, and if we looked at all the warning signs just a little bit more, we'd have this licked. And we do need to do that, and we'll talk about that, but the truth is we've got a lot of work to do. And I'm going to talk a little bit about what that might be. I'm going to tell you a little bit about who I am, so that you have no mistake about my motivations for being here. My mission every day when I get up, and I say this everywhere I speak, and I say this to myself every day, and if you know Bart Andrews, he'll tell you I'm like this all the time. I wake up like this. My mission every day is to relieve severe and sometimes lethal emotional pain. One person, one problem, 1 minute at a time if I have to. Go SPCs. And to be more effective than that if I can. And so I work very tirelessly within VA, and then I have a bunch of activities outside of VA. I'm pretty committed to figuring out how we can end the blight of suicide in our communities and across the world, and especially for our veterans. I currently do this work for VA, and I'm detailed to the Office of Suicide Prevention, largely because I'm so loud that they just couldn't find anywhere else to put me. It's kind of sort of true. I'm Dr. April Foreman. I'm a psychologist, hugs not drugs, skills not pills, right? So you don't forget. And I'm very, very interested in working with folks at high risk of suicide. My particular specialty in the clinic, and I love doing clinical work, this is the last few weeks is the first time in my life I didn't run a special clinic, is working with folks who have borderline personality disorder, and especially folks who have a history of multiple suicide attempts and are at high risk for dying. So this is not only an interesting public health challenge that I get to talk with you about academically, but I work with very high risk folks and folks who sometimes die. So the analog is that I'm the kind of oncologist that works with stage 4 terminal cancer patients. So sometimes I lose some. And so I tell you this, and there'll be some levity. And I love that dumpster fire rap in a felony. I like a sort of a clever and colorful way of saying things, but I want you to understand this isn't an abstract problem to me. These veterans that I serve, I care about very, very much. I want to talk about what we're doing in Big VA to work on serving the sick, so the 6 veterans who are dying by suicide, because we've been talking about having a state-of-the-art breakthrough led by VA to eliminate veteran suicide. Now, that's a pretty ambitious goal, wouldn't you say? Makes people nervous, but here's what I'm going to tell you. The most progressive folks in the suicide prevention community, internationally and nationally, are the folks talking about zero suicide. You can Google that. You have phones. Get them out. Take my picture, put it on Facebook. Also, Google zero suicide. We believe that we probably could dramatically eliminate suicide. Maybe not zero, but effectively zero. It's an aspirational goal. And there have been some healthcare systems which have achieved it. So Henry Ford is a really good example. Verna Little is a psychologist friend of mine. She is chief psychologist for a federally qualified healthcare system in New York, runs about 70 clinics. Dramatically reduce suicides by handling things within their healthcare system differently. Another friend of mine is Becky Stoll, working for Centerstone, which is a large mental health care system, and they've dramatically reduced the suicide deaths within their healthcare system. And it involves a fairly rigorous set of system-wide practices. And so we are working at VA exactly to do that. And we have a few things that are part of that system. I can't cover it all. Do you really want me to talk all day? I do it, but I think you have to, get up in a minute. So I'm going to cover some, but if I forget one, let me know. We have the Veterans Crisis Line, and I love the Veterans Crisis Line, and here's why. So several of my friends, like Bart Andrews, work in crisis centers, civilian crisis centers. And is anyone here a crisis center person or has volunteered for a phone line before? A couple. So here's what you know. If you don't know this, have a minute, lean in. Most, that 1-800 National Suicide Prevention Lifeline, it's largely run on donations and staffed by volunteers. We have some places like Behavioral Health Response that have paid staff. But can you imagine any other major cause of death where most of your emergency treatment would be provided on donation by volunteers? Most of the time we do that, but not for veterans. For veterans, we have the Veterans Crisis Line. It's the largest crisis line, largest staff crisis line in the world, and we just expanded. Anybody can call in, 1-800-273-8255, press 1 for veterans, right? And you'll go to one of our staffs, either in Canandaigua or the Atlanta call center. One of the folks who answer the phone are veterans. We will answer the phone for anyone, whether they're enrolled in VA or not. And those suicide prevention coordinators will get a consult to follow up on within a business day. That does not happen in the civilian world. It is an amazing service. I've been privileged to work in it. I wish that everyone had that kind of attentive mental health crisis care. But veterans for sure have it. We also worked on same-day mental health access. Thank you so much, Dr. Metzger. People are achieving that in all VAs in various ways. And he's totally right. An emergency room is not the best place most of the time to treat a mental health crisis. It's just not. It's not the most effective, and feeling bad isn't a reason to put you in a hospital. As a matter of fact, the research is pretty clear that the outcomes aren't fabulous when you do that. So we've come up with lots of really good mental health access for folks who are veterans that are same day, as well as 24/7 phone line that connects back to your doctor. Civilians do not have that. I did care in the civilian world, and let me tell you, there was no same-day mental health access. So the idea that you might have to wait 6 months to see a medication provider was pretty common. And if you want to know where I'm from, let's just have that minute. All of my people are from 2 counties, one in Missouri and one in Kansas. My people, my father's people, all settled Cass County, Missouri, like the original farmers, and then when cars were then mechanics that settled Cass County, Missouri, and my mom's family settled Glenn County, Kansas. I'm from rural farmers and mechanics from way back, and we're practical folk. And there's just only so many hours in the day and only so many people. For the VA to figure out a system where people can be seen the same day is pretty great. Can't be stressed enough. That's amazing. And I know no civilian healthcare center that is held accountable for that. And so I feel very proud of us. We're working on what's called other than honorable access. So for folks who have been discharged with an other than honorable discharge, we're committed to serving them, especially folks in crisis, and ongoing services for folks who are high risk of suicide. So we've been putting in, facilities have been putting plans in place to help folks with other than honorable discharges. Why would we do that? Well, it turns out that probably the same mental health challenges that are related to having mental illness and a suicide death seem to mean that you don't tend to do as well in the military service. And so we have a lot of folks at risk with other than honorable discharge. We did research and we found this out, and this is one of the things that we're planning to do to meet that challenge. Once again, I know of no other healthcare system that says this is a high-risk group that doesn't qualify and we're going to serve them anyway so they don't die. It's great, and it's specific to VA. We have SPCs. For my SPCs who I just introduced, a quick little story. There's a guy, his name is Richard McKeon. He's the chief of suicide prevention for the United States, a friend of mine. If you haven't met him, he's in his 70s, and we all of us in our 40s all get tired out taking Richard out at night. He usually closes down the bars at 2 or 3, and we fall asleep, and he keeps going. He's an amazing man. No, truly, he's an amazing man. And he tells the story of his first job being sort of like a suicide prevention coordinator. And Ira Katz, who works for the National VA office, several years ago, about a decade ago, had been charged with dealing with the veteran suicide crisis. And they came up with this idea of suicide prevention coordinator based on a job that Richard McKeon had had a long time ago. And they said, if we could do an ideal job providing suicide intervention and preventative care, what would that look like? And they built this job. And there are very few civilian analogs. It's an amazing job. You can solve any problem any day to keep somebody alive and to help them recover. And you have incredible flexibility, resources, and latitude. And I just can't, I know too many SPCs. I love doing that job, and I can't sing their praises enough. And that is how that job came to be. We also have something called Operation SAVE. How many of you are Safe Talk or assist trained in here? So you're like really my heroes. And then how many of you have had mental health first aid? Okay, not so many. How many of you have ever taken CPR? All right, leave your hands, leave your hand in the air. How many of you have taken CPR? How many of you have ever had to use it? Okay. How many of you have talked with somebody who is suicidal or in crisis, either in your personal life? More than have ever come across somebody who's unconscious or in chest pain. So, but very few have had training. So Operation SAVE is the VA's brand for veterans of suicide prevention, as sort of first aid, and like how to talk with somebody who's in crisis, and how to do a warm handoff to a mental health professional. Just like you start doing basic lifesaver interventions and you hand off to EMS or a professional who arrives on the scene. And VA, the suicide prevention coordinators, I'm so sorry to do this to you. They will totally come to any of your community organizations and provide that training for you. Every VA employee gets that training, and I'm responsible for making sure that we update it and everybody gets it every year. So if you're a VA employee and you have to do it again, you're welcome. We also have wonderful research. Yes, question?
VA grants.
Yes.
The SSVF program, things like that. Are they also getting those trainings?
You can. So, like the good news is it's free. So if anybody wants to request it, they can. I don't think we've mandated that if you want to do it, there are people right behind you. You can get that, get that scheduled immediately. It's a wonderful training. When it comes to research, we have our Center of Excellence. We have our MIRICs, which are sort of our local research groups. For suicide, it's the Rocky Mountain MIRIC. I know them. They're my friends. They're like the best. And they do great research. And we have various other acronyms. There's a bunch of research about suicide within VA and the military community. As a matter of fact, most research dollars on suicide are spent in VA and the military community because the NIH doesn't spend a lot on it. Call me, right? As a matter of fact, we spend in this country, just so that you know, we spend about as much in this country on suicide-related research as we spend on smallpox. Do you know how many people have died of smallpox in the United States in the last 20 years? 0. Just a heads up. Just, interesting fun facts. We have something called ReachVet. This is really super cool. So I'm very interested in data science and technology and really innovative approaches to suicide. And within VA and our commitment to the 6, we started doing a big data science analysis of all of the medical records of our veterans who died by suicide in comparison to the ones who did not. And we identified very complicated algorithms, although the science is moving so fast, it's now considered like classic math from like 3 years ago, because that's how fast data science moves. And we can actually crawl roll medical records in VA and identify people at risk of suicide who have never expressed suicidality and have never been in mental health services. Which is super interesting. I know, look at that. Totally cool, science, totally real. It's amazing. The science behind this is great. I happen to know the folks who did this. It's really, really good science. Again, they don't have that in the civilian world. Aren't we lucky? And so we may be able to predict people at risk of death, and there's some science that suggests we might be able to use people's social media data and all sorts of things. But VA and the Department of Defense are the ones primarily doing that really innovative research. So if you're wondering, veterans are certainly at more risk of suicide, and our organizations that serve veterans are leading the way in this public health problem. We also do something, and I know this sounds foolish, we do something called a psychological autopsy. And in VA land, it has an acronym. It's called VHAP, and the folks who do those are right back there. So when somebody dies by suicide, a veteran, whether they're in VA or not, we have a process where we collect a bunch of information about it, and we send it to a big national research agency where we have the only national autopsy program for suicide. The closest anybody comes is a guy named Carl Rustin, who is a suicide prevention coordinator, not in VA, but for the state of Montana, which has a very high suicide rate. And he has the state do this. And so they do a few hundred of those a year, we do thousands. And so we're creating a lot of data about folks who die with the goal of understanding that and maybe preventing a death later. And so families who have survived a veteran suicide can contribute by doing an interview and providing research data in the hopes of maybe making it so that another family does not have to live with this loss. I could go on, but you start to get the drift. This is pretty comprehensive, from very preventative stuff. You see that I sort of get all the way to stuff that we do after somebody dies to understand suicide better. But what about the 14, Dr. Foreman? You ask yourself, right? Or you should be. So I'm going to say this again. If you want to eliminate veteran suicide, even if the VA provides wonderful care, we'll probably be able to save a few lives a day, but those 14, the majority of veterans who die by suicide, they're in your community, in the mental health systems that all of you use. There is no special program that is going to just find these 14 and get them outside of having robust and healthy mental health care infrastructure in your communities where veterans live. VA can't do it alone. We need strong partnerships. And we need strong veterans to advocate. And I'm going to tell you a wonderful story about this. In the state of Louisiana, the parish, they don't call them counties, they call them parishes. The parish where they have the highest suicide rate is a parish called St. Tammany. It's not far from where I live, and I'm on a special little organization in there, and they're working to eliminate suicide in that parish. And they understand and invited VA to the table because we provide services, but they're working on improving their crisis services and building all the infrastructure, training law enforcement, who are usually the first mental health responders. That's just the way our system works right now. If you don't care for that, I'm sure that there are state advocates that you can talk to. But for right now, that's law enforcement, and I love law enforcement and work with providing the mental health training for veterans in distress. That's a great thing. And then all the way to your emergency rooms and how they might interact with veterans at risk, how we might do a handoff, how we might find out if someone's eligible for VA and get them from a civilian hospital into VA hospital, SPCs. I'm sure you've done this where someone's in a civilian hospital, you get them enrolled and transferred into VA care after a crisis call. Totally have done that. We do that all the time. Like I said, I know no other kind of crisis mental health care where somebody serves you even though you're not enrolled in any kind of care plan. They get you enrolled, they transfer you there, and they cover the bill and then call on you when you go home. Like, that's how VA does it. We have wonderful local outreach and partnerships. Those SPCs back there, not only can they do Operation Save, they can come visit you. SPCs do about 5 outreach events a month or more. That's how we have strong relationships with our community. We have state suicide prevention coalitions. Come out! Come out! You were mentioning this to me, so tell us a little bit about who you are.
My name is John Sabal with the Missouri Department of Health and the Veteran Services Director. So we develop programs, policies, recommend legislation to help meet the behavioral health needs of service members, veterans, and their families.
And there are absolutely state suicide prevention coalitions of various forms, and you have folks who represent veterans' mental health for your state and your communities. You need to have strong partnerships between VA and the folks who do veteran health care outside of VA. And we work on those all the time, and we say hello, and you'd see me on the YouTubes, which is true, sad, but also true. The VA also has a number of national and federal partnerships with suicide prevention organizations. I'm either representing VA or representing someone else. I think probably half of those, and probably more than that. And we do wonderful work showing up to National Suicide Prevention Strategy. Eileen Zeller and Richard McKeon, Dr. Richard McKeon are the folks who do this for you, for the nation. And VA is present for that, as well as the Department of Defense, and that's a woman named Keita Franklin who directs that. And the Action Alliance, who does messaging about suicide. We show up to those meetings. There are all sorts of wonderful advocacy groups. We show up to those meetings. The National Suicide Prevention Lifeline is run by a friend of mine named John Draper, and that's a contract owned by Mental Health of America, which is provided by SAMHSA. We show up to all of those meetings. We have partnerships at the highest level with all of these folks with the goal of it trickling down into good suicide prevention care in your communities for those 14 veterans who will not come into my clinic for whatever reason. Humanitarian access, so anybody who accesses the Veterans Crisis Line or shows up at the VA's door, we will take care of. We won't leave people in a lurch just because they're not enrolled. We provide wonderful training, not just Operation Save training, but there's all sorts of, through many outlets within VA, we have wonderful training for civilians on mental health and military culture. I think someone was asking me about that, and you agreed to pitch me a question. It totally won't look planned, right? And then we work on public and private innovation partnerships. So the way I get into VA at all, so that you know, I was practicing mental health in rural Kansas. Like I said, all of my people are from rural Kansas and rural Missouri. And I was back home because all my husband's people are from Lafayette County, Kansas. And I was practicing not far from there. And I got recruited into VA because I did a bunch of innovative stuff with data and technology and mental health. And the VA said, and they were the only ones that said, we love your specialty, we're not afraid of it, because it was a really new frontier back in 2010 when I started. And they said, we will totally support you in being innovative. If you come be an SPC and turn the crank and really do a good job, we'll let you develop yourself and contribute back some of your specialty and expertise to Big VA. VA does wonderful partnerships with people like IBM or Johnson & Johnson, or with fabulous data scientists, or the White House Opportunity Project, and all sorts of wonderful ways that we work on the most innovative suicide prevention projects that you will see in the world. And VA is connected with those on a national level. If you want to ask about those, give me 3 hours, right? No one wants to give me 3 hours. But you get the idea. This is what we can do for the 14. I'm going to do a whiz-bang finish, but before I do that, I want to make sure you have my name and my contact information while you're still conscious. Probably the best way to stay in contact with me is through Facebook. I know, middle-aged, on Facebook, but it's really true. And I have a wonderful network of folks in suicide prevention that if you do need something, and it may be in VA, but it may be not in VA, I will do my best to help you connect with someone. So totally friend me on Facebook whenever I present, and I present both for VA and a lot of other capacities all over the nation. Like, this is how I stay in contact with folks, and I want to make sure that the folks in Missouri have great suicide prevention care. And so if you hit me up, I will do what I can to help you with that. You can also email me at April, like the month, .foreman, like George, at va.gov. And you can find me on Twitter as @DocForeman. There will be a lot of suicide prevention content in my social media feed. Brace yourselves. We're going to get to questions, but here's where you come in. I can do a lot for the 6. They can do a lot for the 6. Dr. Metzger can do a lot for the 6. But really, to eliminate veteran suicide, we're going to need you. It's not possible without you. Some things that I need for you to do. Get Operation Save training for your organization. There are other kinds of gatekeeper training as well that are great, that are not free, but there's Safe Talk and Assist training through Living Works that are great. Happen to know those folks. It's the gold standard. There are other forms. There's mental health first aid that you can get in various ways. Get mental health training for your organizations. Assume that it's just as important, if not more important, than CPR. Ensure, if you were at a meeting in your community about mental health, and ensure that VA has been invited to the table because they have all these mental health resources. Call those SPCs back there and invite them to come attend your meeting. They get time to do that. They have wonderful latitude to come be involved in the community and help you access resources and know what's happening in your local VA. Make sure that veterans, especially veterans who've survived suicide, either they've survived suicide losses of others or they've survived their own suicide attempts, make sure that they're at the table when you're planning suicide prevention in your communities. They're invaluable resources. We call that lived experience. So we have folks who've survived suicide loss and folks who've survived suicide attempts. Invite them to the table, especially veterans. I have several friends who are suicide attempt survivors, and they've taught me so much about suicide. Use your networks. You guys have big networks. Cover the state. You guys can reach so many people with messages about suicide prevention and public health. Use your networks to amplify accurate and effective messages about veterans and suicide. I can promise you that there's plenty of media that says that the trauma of war was just too much. We understand why he had to kill himself. That is not the story that you should be amplifying. Number one, it's not true. We don't understand suicide well enough, and what we do know is that just experiencing a traumatic event isn't what leads to your death. It's way more complicated than that. And the minute that you give an inaccurate or overly simplified narrative of why somebody died by suicide, we just start to give everybody a story that it's helpless, that it can't be stopped, and there's nothing we can do. Use your networks to amplify that suicide is preventable. Our goal is to eliminate veteran suicide. There are resources in place. When someone has died by suicide, these SPCs back there, when a veteran's died by suicide, they can do post-vention. They can come visit those communities. And because we know that surviving a suicide increases your risk from dying by suicide. So we can do post-vention. We can help people. The number one question that I get asked, sorry. So part of our job is that we talk to folks who survive suicide, sometimes in the immediate days following a death. You guys have done this, I know you have, right? So how many of you in this room done that? Somebody comes in my office and someone they love has died by suicide, maybe in the last couple of days. And the first question that they ask us is, why and what do we miss? I would be a bad scientist and a bad psychologist and a bad human being if I said that we knew the answer to that, because we just don't. What we tell them is we're not entirely sure. There are very smart scientists that are working on it. In the meantime, we will take care of you, and if you want to help us prevent this from happening to someone else, boy, we got a deal for you. And then we take the best care we can of survivors. Please do help me to, number one, I want to have fewer of those conversations, and I'll do whatever it takes, and if you call me, we can do a lot together. And when we do have to have those conversations, let's take advantage of the passion and the energy and the goodwill to prevent this, and work together. This is a little hokey. Follow me down this road and I'll take questions. I would love for you to imagine a world without suicide. You're hearing about it in the news all the time, right? Everybody's seen 13 Reasons Why on Netflix. That's another whole conversation. Imagine a world where suicide really isn't the 9th or 10th leading cause of death, where it's really, really rare. Imagine that we've solved this problem. Ask yourself, in this world where suicide is eliminated and it's no longer a painful blight in your community, what did veterans and VA do to lead the way? And then ask yourself, how can I help make sure that that's the future that happens? And then call me. Thank you so very much. Did you have some questions for me? Or did I do that good of a job, or is your blood sugar that low?
You talked about post-event,
Post-vention?
right. So you would, did that, what I was probably communicable?
You know, communicable is not the world's worst word. What we know is that people who survive a suicide loss are more likely to die by suicide than other folks, and we don't always know exactly why. So, I think of units that have multiple suicide deaths way more, and so we know there's a contagion effect. We don't always understand why. We know that post-vention, like ways of helping to debrief people and connect them with resources, may be able to reduce harm and possibly reduce the effect of possibly going on to die by suicide. And so I'm thinking of a unit where we had a suicide cluster, and I visited that unit a lot to try to figure out what we thought was driving that. And we eventually, because not only did we have deaths, but we had multiple attempts and multiple folks who were really at risk. And it was a very small, geographically limited number of mortality. And so we did a lot, and we figured out what the deal was. Did you want to know what the deal was? I'll tell you what the deal was. So we figured out with this particular unit, they had almost all grown up together. They had been in abusive rural Louisiana together with families that had some interesting functioning issues. They had some pretty interesting tales to tell. They all used drugs together. They all joined the military together. They all continue to use while downrange together. They all came home together, all went back to the same rural place where they couldn't find good jobs together. And then they all tended to attend or die around the same time every year. You'd think it was an anniversary date about trauma, but it wasn't. They all would get on Facebook the same time every year, and they would watch YouTube videos of some of their firefights. I don't know if you know people can do this, but pretty much if there was a firefight while people were deployed, someone recorded it, it's probably on YouTube, and I can find one for every unit if I want to. It's super scary. And they would all talk about some of their particular events, and they would use drugs while watching them. And and someone would get very, very destabilized because it turns out drug use is not really good for preventing suicide. And someone would attempt or die. And so what we did with that particular group was we said, during the month of November, you're all going to turn off your social media. And during the month of November, you're going to plan a crawfish boil and go fishing. Because in that particular area, everything is surrounded by water, and y'all go fishing and y'all have boils. You know, do you guys have? You have crawdads in Missouri. I remember, I ate them. But in Louisiana, crawfish bowl. So they have a big event, and they turn off their social media, and they all hang out together physically in person, and they're working on being clean and sober. And they also all know me, because I went and visited them a lot, and they were law enforcement, and we retrained everybody in the region. It was quite an effort. And we just got to know them, and their mama, and their girlfriend, and their babies, and their friends. And then if somebody was in trouble, they all agreed to call me. But they wouldn't call me if they were in trouble, their friend would call me. And now that some of them have gotten jobs and moved away, they still call me. So I'll get a call from, you know, John Smith over there, and he'll be like, well, Joe Smith, he's not doing well, so go find him, and we'll go take care of him. And VA can do, the SPCs can do this kind of really good public health care, largely because of the very unique nature of how we're set up. You can do, there's other kinds of postvention that can be done, and we can do it really, really specifically to a group of people. And that's pretty powerful public health, and I'm really certain there's some people who are alive because we did that. Something that's possible. That's a great question. Other questions?
I experienced a story of a guy that said that his dad was in trauma at his job because the feds came in, and a big audit, and the dad called his son, and he was very prone to suicide for this happening, and the counselor immediately dropped everything and came there. And what prevented his dad from doing anything drastic, the counselor immediately said, how many kids do you have? He said 5. He said, I want you to pick which one, because the high percentage is one of those is going to commit suicide.
Possible, yeah.
That's happening out there. Is that true?
So one of the things that we do for preventing suicide is we talk about reasons to live, and we do talk about your death will not end the suffering of others. There's a cognitive distortion folks at risk of suicide do. They believe that they're a burden and that their death will relieve others' pains. They're not thinking clearly. And so we remind people that it will be very, very painful for everyone if you die. That the goal for preventing a suicide is often, you really only need to intervene for about a 30-minute window when someone's really, really distorted. And remembering reasons to live and remembering that your death will be very painful for others can be helpful for some people. But just like I said, the researchers aren't for sure what works. I don't want to tell you that works for everybody, and the research tells us that that works because the research isn't as conclusive as we wish. Does that help?
The conference is centered around veterans, but also brought up the issue of first responders.
Yes, absolutely.
Those are folks who are not only responding to suicide, but also have high suicide rates.
You bet.
In those professions. Is there anything that you can add that would address those populations that we can?
So a lot of first responders have some of the same issues as veterans. What we know is that for veterans as well as first responders who die by suicide, they largely die by suicide using firearms. And first responders and veterans are very comfortable with firearms and they own firearms. Now I know I just brought up guns in Missouri. Don't shoot me because I'm a gun owner too. And I talked about that on YouTube with some of my guns 2 nights ago or 2 weeks ago. So I'm not. See, we're not going anything dicey or dangerous territory, but we do know that first responders, and many first responders are veterans, like there's a significant amount of overlap, see very, very traumatic events. They have higher rates of PTSD as well. They have higher rates of substance abuse as well. They have a lot of familiarity with firearms as well, and that is what we think may be driving the mortality rate. It's fairly complicated, but a lot of the things that we talk about, having a robust community mental health system, doing mental health outreach with the, with your first responders, with your law enforcement, with your firefighters, reminding them of what the resources are for them. In Baton Rouge, they started a special PTSD clinic, PTSD and substance abuse sort of day program. And they got a grant so first responders had a much reduced rate and they could go access mental health care around their jobs, which was very good.
This is very political action.
Thank you.
A couple of quick comments.
Sure.
One,
we've had issues with running into suicide pacts before, and that's kind of hard to prevent if there's completed suicide. You don't really know who else might be involved, so that's where we've seen sort of a cluster coming in.
And that means like regionally here, right?
Regionally, right, yeah. So that becomes an issue sometimes. And the second, I think once someone has taken the action of trying to kill themselves, it just makes it a lot easier to repeat that action.
Yes.
I think that really puts them at a much higher risk. That's one of the reasons why we see that.
Can I talk about, that's called, Thomas Joyner is a friend of mine, it's called acquired capability. So basically, there's a line inside of you that makes it hard for you to kill yourself or other people. There's a lot of research behind that. It turns out it's incredibly hard to do. And so you have to sort of practice to overcome the sort of urge for self-preservation. And so folks who have attempted suicide in the past have a lifelong increased risk for suicide. So it's like having a risk for cancer, like you've had cancer once and survived it, so your risk of it coming back and being your health, that's a very similar deal. And so it's really important, if you know someone's attempted suicide in the past, to just, all of their health care following that should be extra attentive for all of their life, forever. That's very, very important. Having more providers who are comfortable asking about suicide. And here's the thing, and I work with folks with borderline personality disorder, and they do things, and everyone goes, well, they don't really mean it. They weren't really suicidal. They're just trying to get attention or affection, or they're being manipulative. Lean in again. If someone's trying to get attention by threatening to kill themselves, it's a sign that something's really wrong, because that's not normal. Okay? And it usually, and by the way, folks who do that usually do have a lifetime prevalence of suicide anywhere from 3 to 10%. So it's literally the most lethal mental illness you can have. So even if you feel like someone's not serious, if they're doing something like that, it's a big red flag. It's a big red mental health flag that they have a lifetime risk. And so get them help then, but if you see that in someone's clinical record in the community anywhere else, get them good service. I did that right. So if somebody dies by suicide, it absolutely puts their children more at risk. It doubles or triples the risk for the children to die by suicide later in life. And we're not entirely sure why. But that's an excellent reason to prevent it. If you prevent one suicide, you may prevent the ripple effect later.
Hi, Doctor. I have a question related to children of...
Hi, Doctor. So I got a lot of questions to down there. I do have a question about related to children who have experienced, the passing of a parent. Does the age in which the age of the child at that time, did it make any type of a difference versus like a child versus an adult?
So do you want, you remember that part where I said we don't fund good research at the high enough levels? That's my answer. I did that right. So if somebody dies by suicide, it absolutely puts their children more at risk. It doubles or triples the risk for the children to die by suicide later in life. And we're not entirely sure why. But that's an excellent reason to prevent it. If you prevent one suicide, you may prevent the ripple effect later.
Hi, Doctor. I have a question related to children of...
Hi, Doctor. So I got a lot of questions down there. I do have a question about related to children who have experienced, the passing of a parent. Does the age in which the age of the child at that time, did it make any type of a difference versus like a child versus an adult?
So do you want, you remember that part where I said we don't fund good research at the high enough levels? That's my answer.
Okay.
So one of the people who does research that, by the way, is one of my friends. She's the current president of the American Association of Suicidology, Dr. Julie Serrell, and she does research on suicide survivors, loss survivors, and what we know is that it probably doesn't matter what age, it probably just matters how close you were to the person who died by suicide. So if your very, very best friend dies, even as an adult, your lifetime prevalence for suicide is higher.
You mentioned one of the preventative measures that is being taken in the VA is that folks who have, I'm sorry, not enough, I really am. Folks who have had or have an other than honorable discharge are now being welcomed in and looked at mentally and such. Is that trickling into other services that the VA provides, for example, homeless veterans?
So the idea that we would serve folks with other than honorable discharges is fairly recent, and the very first meeting that I was in was just not even so many weeks ago when we had no idea what the policy was going to look like, and that I would think it would be fair to say still in flux who's going to be included and who's going to not be included in the service of reducing mortality. What I can tell you is if you want to know what's happening locally, Fred is a wonderful contact because if policies happen or change, Fred's probably going to know.
Well, there's not been any clear direction right now, but
Thanks for backing me up on that.
So there hasn't been any clear direction right now. But from my perspective, homeless services at St. Louis VA is under mental health services, okay? And if it's under mental health services, I consider it a mental health service. And until I get direction otherwise, if somebody comes in and needs homeless services and they're other than honorable discharge, we will serve that veteran until I get direction otherwise.
Yeah.
Aren't the service connected always taking care of them?
Yes.
What was the question?
If someone's service connected, aren't they taken care of otherwise? And the answer is yes. And I'm very concerned about time. I'm looking at the general. I'm going to make sure and pass the microphone. I will be on Facebook. You can just shoot me more questions. I have 2 minutes. I can take 1 or 2 more questions depending on how chatty I am.
All right. I think, I'm a third-year vet and been deployed a few times, I think it starts with being in the military before you're ever out with, for a fact, that the military has pushed things under the rug, especially when it comes to women and MSTs. And I think if we fix that problem, I think that will help when they're out and they're using the VA services. So I feel that our numbers are higher now because a lot of the services swept things under the rug, and especially with females. I think there's a big problem with that. I think if they fix that, it would reduce the numbers for women especially a lot.
So can I talk about something called invalidating environment? Would you be cool with that, Gina? All right. So for the folks that I serve a lot of folks with borderline personality disorder, and one of the ways you get that is something called invalidating environment, where at a really critical developmental period, you have a tendency towards mood disorder anyway, and then the environment doesn't really, it sort of acts like what's happening to you is not happening to you, and it doesn't give you it doesn't sort of validate that what's happening to you is real, and doesn't tell you how to respond effectively. And when that happens, it increases people's distress, because at very important points, you guys remember being 22, where, certainly I wasn't wrapped in a dumpster fire and a felony, but being 22 is not easy, right? Can you imagine if you were experiencing really painful trauma or challenges and your environment pretended it didn't exist or didn't tell you what to do about it? If you're 22, how would you know how to handle it otherwise? And so we know that at key points when you're a young adult, if you don't learn, if your environment doesn't teach you how to handle things because your environment either doesn't fit the pain, the disruption going on inside of you, or it's actively ignoring bad things that are happening to you, it can absolutely lead to mental illness and the kind that puts you at risk of suicide. We do hope, I think a big lesson for this is when somebody is in pain and they tell you a story about it, suspend disbelief and believe them. It turns out that nobody is asking you to be a judge of the truth of fact. What they're asking is for you to listen and believe that their pain is what they say it is, and that there's a lot that you can do for people's well-being by doing that. You promised to pitch me one really good question.
You said at the end.
Yeah, it is. It's like the end. It's like the last minute.
So if you give some tips or advice, I haven't thought about this. Some tips or advice for clinicians working with the military community that are not military connected on how they can better serve that population.
I was really excited to get to work for VA, and I got recruited to do this, and I hadn't worked for veterans before, and I remember asking for this advice. And now that I'm a few years in, here's my advice back. Having worked with a bunch of veterans as a civilian, I never pretend to understand things about what it means to be a veteran, and what veterans have taught me is I'm not going to understand. I can be validating, I can ask questions, I can learn a lot about what it means to be a veteran, to be active duty, but I should always let the veteran tell me what it means, especially what it means to them, number one. Number two, I would say get very, very comfortable with, how am I going to say this? I was a little bit more humorous. But I'm trying to say it nice. And I like working with veterans better than civilians, and this is why. I'm a little upfront, and especially for good Midwesterners, I'm a little bit direct. And veterans are very direct as well. And sometimes people feel that directness and that call a spade kind of behavior, they misperceive it as intensity or aggression. And so one big piece of cultural competence is I've never had a veteran who hasn't appreciated just being told up front what's going on. Those normal social behaviors of sort of being gentle and a little, easing people into things have not generally been as appreciated by veterans and military service members. And so just saying, this is what the situation is today, tends to relax people. And the very third thing I will say, and again, this is Missouri, so I may not have to say it. Most folks who die by suicide, veterans and civilians, die by firearm. Most mental health professionals are not firearm owners. Most primary care doctors are not firearm owners, unlike me, sadly. I don't know. I won't put a judgment on that, it just is. I think that probably, if we wanted to reduce suicide, having really becoming culturally competent about guns and firearms, so that when you talk about something called means restriction, so when you find out someone's at risk of suicide, you should be discussing, so where are the guns, and what's our safe way of storing them, and what you should be talking about that. You have to become a lot more comfortable talking about guns, and you have to become a lot more comfortable talking about suicide if you want to eliminate veteran suicide. Now, how many people in here feel pretty comfortable having a conversation about locking up and storing firearms on a safety plan? Way to go, Missouri! What we need to do is make sure our mental health providers and our primary care doctors who provide 80% of mental health care, primary care in your communities, that they are just as comfortable as the people in this room. Probably we could save a lot of lives if we just learned how to have comfortable and appropriate conversations. How's that? And I've ended on time, I bet. Fantastic. Thank you so much for that.
Thank you, Doctor. And it really was enlightening. Thank you very much. And please accept from ABEN our certificate of appreciation and the much sought after and highly anticipated Cossack coin down yours. And you get your list of Army goodies here to take. So thank you.